Please join me in welcoming the Honorable Four Price and Joe Moody. Rep, thank you. Appreciate it. Yes, sir. Good. Thank you. Rep, thank you so much. Come on, sit. So today's conversation gives the lie to the idea that there are no bipartisan issues in the Texas legislature.
That's true.
Is that right? I mean, this is, Representative Price, this is really something that there does not seem to be the kind of partisan fighting over that we see with almost every other issue.
That was one of the most refreshing aspects of the committee's work was that we were fortunate to have a 13-member committee from all regions across the state of Texas. We had urban representatives, rural representatives, suburban representatives, Republicans, Democrats, 13 members. Everybody was very engaged throughout the process, and it really didn't matter what party you belonged to or what part of the state or what region you lived in or represented. Mental health and behavioral health and the issues that are associated with it were common across the board, and everybody pulled the same direction. I'm really proud of the work the committee accomplished, and that was a great aspect of working on this whole area.
Yeah, and Representative Moody, I think this to this point, you know, one of the reasons it may be bipartisan is that this particular affliction, and it's a continuum, it's not one thing. Not mental health does not mean the same thing to everybody you talk to about it. Everybody has somebody in their life where they know somebody who has been in some way touched by this, so it's a very personal issue.
Yeah, I think that's why it's really easy to cut through some of that stuff. And, Four and I were talking on the floor the other day, trying to figure out ways that we could spar for you here, but there just aren't any in
There's I'm going to, believe me.
So, no.
Don't make me bring up the bathroom bill. I will do it, actually. If this gets boring. Okay.
There's lots of stuff to talk about here, so I think we'll be okay. But no, it's been a real pleasure to work on this issue. And I think it goes to your point. You are just as likely to have someone in your family who has a substance abuse, mental health, behavioral health issue as you are someone who has cancer. And so we need to start talking about these things the same way. We just deal with them differently. And that's what I want to thank y'all for doing this, because part of it is not something that we do in the Capitol. Part of it is just having a conversation in a broader way and normalizing the conversation about mental health. And you hear the phrase "end the stigma" and things like that. These are the types of conversations we need to keep having. We need to foster that level of communication across all the.
So let's, for everybody's benefit in the room, let's talk about exactly the process that you all went through, because it was a bounded process. So the Speaker announced the creation of this committee in November of 2015. It was a 14-month, as I do the math, exercise. Report came out in December of 2016. Over the course of this, you had 8 days of hearings, 40 hours of testimony, 100 expert witnesses, but you also did a whole bunch of site visits. You really, Representative Price, toured the state.
Correct.
And you covered the gamut. I mean, you went to facilities, you went to see individuals. You kind of talk about the thought process that went into the fact-finding that you did over the course of this.
Well, the catalyst for the whole effort was really the Speaker's proclamation. When the committee was formed, there's a proclamation which set forth the charges, the areas that we needed to study. And frankly, if you read that proclamation, it's in the appendix of the report. It is quite lengthy. It's very broad. And so we grouped the issues accordingly so that we could sort of in an organized fashion undertake this analysis and get the work done within the year so that we could produce the report that we did. And so it took a lot of effort to really organize that information to not only, as you mentioned, have over 100 expert witnesses, 40 hours of testimony. A lot of work goes in on the front end to sort of filtering down what will be representative for the whole committee to hear, what will be most useful, and what will be informative, and it's tough because these are such broad issues. There's so many people across the state of Texas that you could have. We did the best we could, and I think we had a great representation of public testimony, expert testimony, folks from state hospitals, from higher ed, from K through 12, from criminal justice, from the veterans community, homeless community, substance abuse, et cetera, et cetera. And at the end of the day, I was very encouraged, and our eyes, I think, as a committee, were open to, similarly to what Joe was saying just a moment ago, how prevalent these issues are, how many different folks are affected across the state, and really what costs are going to be involved if these issues aren't addressed and invested in.
Because it's pay now or pay later, and the pay later actually turns out to be quite a bit more.
That's correct.
It's the numbers and it's the range, Representative Moody. This was what jumped out. So this report that you produced, a 109-page report. It's a big report. It's detailed. It's got a lot of appendices. It's got a lot of good reference and research information, but it's got a lot of observations about the magnitude of the problem. And all of us who live in the public arena, do work in this space, think we know more than we actually know, it turns out, about this issue. And I was stunned to read some of these numbers, and I thought it was actually worth, again, for the benefit of people here. 1 in 5 Texas adults have some kind of mental health condition. 1 in 17 Texas adults have a serious mental health condition like bipolar disorder or schizophrenia. There are 1.7 million veterans in Texas with a mental health condition. There are 20,000 people in county jails who have a mental health condition. Of the 32,000 kids in CPS, and we're talking about CPS during this session, as we ought to be, 50% of the kids in CPS have a mental health condition. 26,000 kids in special ed have a mental health condition. And I thought this and because, sometimes you can't get anybody's attention unless you talk about the economy, right? This was the one that killed me. Half of the adults in Texas with some sort of a mental illness are below 200% of the poverty level. So that actually you connect treatment of mental health on the front end with the economic health of the state down the road, right? With the lives of people, but also ultimately with the overall economic health of the state.
Yeah, and I think that's really where the rubber's going to hit the road with this session is how do we want to adjust things? And, Speaker Strauss has put this issue front and center. Other people have talked about it and talked around it. The Speaker in creating this committee and really giving us broad range to work on this topic. Yep. And it wasn't just go study the issue and report back to us how things are going. It was tell us how we transform mental health care delivery in Texas across the board.
So this is not just an academic exercise. The point is make recommendations, meaningful recommendations that we could implement.
Yeah, that was the directive from the Speaker's office and the chairman. The chairman and his staff did an amazing job of working through a wealth of information. But like you said, if we don't, I think the one thing that was clear to me as we went through some of the testimony is we don't identify these issues early enough.
Yeah.
We don't, with the numbers that you cited, those are numbers that we're probably still not reflective of the true issue here in Texas because we're not doing a good job of identifying issues early on. And the more we do that on the front end, so then we can track people out of being, super utilizers in our county jail and our emergency rooms. And so much like, and I keep going back to this analogy, much like someone who has had a bout with cancer, someone who has a mental illness, if they identify it early and they address it early,
it's treatable.
It's treatable. You can work through those things. And yes, you might, much like with cancer, you may have another bout with it down the road. You may go into crisis if you have mental illness down the road. But if you track out early and you get the resources that you need early, there's less likelihood of you having those problems.
So a lot of what comes up in this report is the importance of getting to kids early, right? That's a big thing, and I want to come back to that. But Representative Price, I want to ask you kind of a real politics, meat and potatoes question. This budget cycle sucks, right? We have a shortfall of what, between $6 billion, optimistically, it could be more. Everybody's going to be left with their hand out at the end of the session. Every session is like that to some degree, but everybody is going to be asking for more than they're actually going to get. And there are some very big ticket items that are really top priorities for people. And I think that everybody agrees on mental health on the one hand, but on the other hand, how do you break through the noise? We've seen the draft budgets. We know that the House does about $160 million more in funding for behavioral health. The Senate is just below $100 million. Both make small increases in what are nonetheless austere budgets. How do you get people's attention and make this a priority compared to other things?
I think the short answer is I'm optimistic that both chambers have prioritized the issue, at least their opening statements, and when you look at the proposed budgets, this is not an area that's seeing, widespread reductions, and so there's some desire.
No one's talking about cutting.
In leadership, that's correct. So that's a great sign right off the bat. Yeah. And so, you talk about cutting through the noise. Part of the problem that's really faced behavioral health throughout history is that these are complex issues that don't have a simple solution, and so a lot of folks push them, down the road while the other raging fires that they want to address can be addressed. But I think we've collectively come to the point where we understand the economic, the societal, the criminal justice, the medical costs of not investing. And so whether it be at the state hospital level, whether it be at the local level, whether it be through programs and contracts with OSORs, the things that we have to invest in to prevent increased costs down the road, just like you said, pay now or pay later. I think no matter what, folks may not understand the nuances and the complexities of behavioral health, but they all understand the bottom line. And so if you don't make those investments now, and it is easy to explain, what those costs are. I think in our report it would show we have over $680 million in criminal justice costs for inadequate treatment and over $1.4 billion in unnecessary emergency room costs. And those are being paid for at the state level.
Right, so if you could just get that money back, or a portion of that money back. Right.
And we're trying to get to the point where the resources are better utilized.
Right.
Because you have $6.7 billion in behavioral health spending, including Medicaid, currently.
Right.
We have great leadership opportunities across state, but the treatment should not depend on your residence, where you live and the region you live. And so many differences occur across our state that I think we are doing a good job at bringing some innovations and treatment practices to the surface so folks all over the state can replicate those, can duplicate them, can scale them to their communities. And one of the side benefits of this whole process was we saw time and time again stakeholders come into our committee room or into our offices and discuss what's going on, and whether it be, for instance, a local mental health authority and an education service center who had never talked to one another before from the same community in many cases. They left this whole process saying, we can help you with that, or this could be a program.
Right, because they both have a version of the same issue, right? They each have their own piece of it, and they have not been making that connection. So you mentioned the 6 points. I'm glad that you brought the specific number up. So the way that breaks down is it's $3.6 billion appropriated by the state, and then there's $3.1 billion from the feds via Medicaid. So the $3.6 billion is across 5 agencies. Is that right?
It's across 18 agencies.
Pardon me, it's across 18 agencies.
5 articles.
5 articles. 5 articles, 18 agencies. So 6.7 out of what is the biennial, 209.4 billion in the last that's not very much. When you consider the magnitude of the problem that we've just articulated, and you consider the cost of not dealing with it, why are we only spending that much on this problem in a budget of this size?
I actually think that $6.7 billion, maybe in comparison to a $209 billion budget, is a small number, but it's a significant investment of resources.
Is it enough?
It's never enough. I mean, you could actually go into any area of state spending, whether you look at higher and public education, which accounts for just over 37% of our budget, or health and human services, which counts for just under 37% of our budget. We have dramatic needs in just those 2 areas, but just those 2 alone account for almost 75% of our spending. So you add on to that criminal justice, natural resources, transportation, those are big areas.
I understand the budgetary hellscape that you work in. I get that. But I want to push you a little bit, because like if you're CPS and you've got a crisis, and there is a crisis now that everybody acknowledges, they actually put a price tag on what they needed. Now the House and Senate in their draft budgets gave them significantly below what they asked for. That happens. It's happened over time, and it happens especially in tight budget cycles. I went through this 109-page report. I didn't see a number. I didn't see a number where you all came out and said, this is what it would take.
Well, I don't think that's really what we were tasked with doing. I think it was identifying. No, I don't. I think it was identifying areas in which we could transform the mental health system. And I think the chairman did a good job, because it's not like we didn't know we were going to come into a session where the budget was going to be.
Everybody knew.
Tight. Everybody knew that.
Right.
So the instructions to people coming forward to this committee were, look, we know that we need we need more beds. We need to expand resources. That is a given. We're going to have to figure out how to do that in a tight budget cycle. So we also ask people structurally, what are things that we can do at TDI? What are things we can do at TEA? What are things we can do structurally that don't carry a big price tag, that are actually going to change the way.
Right, but Representative Moody, but everything you're talking about presumably has a fiscal note.
Well, I mean, to some.
No,
I don't think.
You don't think so? So you think there's things that can be done at no cost or at such a low cost that we wouldn't notice it?
Well, yes. A good example of that would be the mental health screening for the kids. I mean, a lot of that is open source material that, I mean, they're getting these exams anyway.
Yeah.
And we just don't include the mental health component except in a certain, at a certain age. We need to include it over multiple years to identify these issues. That's not, I don't think that's going to carry with it an added expense.
Well, presumably the training of those professionals administering that screening would have to have some costs associated with it.
But see, they're already doing that screening with one age group, and so we just need to expand it so that we catch things. Because what we heard, at least what I recall during testimony, was it's great that we do it. We don't do it frequently enough to catch folks and be able to track them to services.
I guess I want to stay with this idea because you get nothing in this life without asking. And so not quantifying what the amount you would need to do this properly means that you're not going to get it. You might not get it anyway, but the number that's in there didn't come out of thin air. So the 162 that's in the House side or the 95 that's in the Senate side, that is against Representative Price what, in the most optimistic scenario, that you would need to do everything you need to do in an a la carte report like this?
Well, if you take a look at the report, there's a couple issues there that I think need to be pointed out. One is that we aren't the Appropriations Committee. So that our goal in our charge really was not to put a price tag on every innovation or best practice that we could identify.
Right.
But we did identify gaps, and we did make recommendations with respect to best practices, which I think is key because many of the things that are recommended, yes, require an investment of additional funds. The exact amount will depend on how broad some of these innovations are applied, whether they're pilot programs or broader. But more importantly than that, whether we do that now or whether we lay the foundation for doing that in 2019 or 2021, or getting people thinking about some of these issues so that you lay the groundwork for progress, not just in this 2-year cycle, but we took a longer term view.
So the spend may happen over time.
Yeah, absolutely.
Right.
And some of these innovations, some of these best practices can build on one another. So it's near impossible to expect the state to solve some of the challenges, but we can manage them significantly better with increased effort.
So you got $3.6 billion that's associated with 18 agencies, 5 articles. That's the state piece. And based on the House budget at least, because that's really all you have the opportunity to affect, that money is in there again plus a little bit more.
Correct.
The $3.1 billion from the feds is interesting. Let's talk about Donald Trump and mental health. I thought I would just let that hang out there. Do you have any reason to feel with certainty that you're going to have access to those dollars from the Fed? Does anybody have any idea what the hell is going on this, on health care? Do you know?
I think there's a fair amount of uncertainty with respect to...
Understatement of the decade, right. Yeah.
With respect to health care, but I'm optimistic with respect to potential flexibilities, for instance, with block grants and Medicaid. We've talked about that for a long time, but haven't felt like maybe that was likely.
Got the best chance now that you've had probably in all the time you've been in the legislature, right?
That's correct.
Yeah.
And so I don't think anything is necessarily off the table, but it is somewhat uncertain. So we do have, I think, an obligation to pursue what we think is best for the state of Texas with respect to our programs and initiatives. And what happens at the federal level, we will adjust. But I'm confident that we have opportunities now that maybe didn't exist previously.
A couple weeks ago, Representative Moody, my colleague Marissa Evans, who reports on healthcare for the Tribune, talked specifically about the question of whether mental health benefits in the Affordable Care Act and substance abuse opportunities that were also baked into the Affordable Care Act might be specifically at risk. If you undo the Affordable Care Act, does everybody who was enjoying the opportunity to access those benefits now suddenly slide back? Does that concern you?
Yeah, I think it's one of the largest concerns and question marks that we have going forward. We had a lot of discussions in the committee about the waiver that we're working under now and some of the programs that are going on through that. And that was, it was stressful to see that was, just to get that extended.
Yeah.
But at least people on my side of the aisle were hopeful that going forward, we would see some stability and some concrete things form around the Affordable Care Act, and now all that is, all that's out the window. I'm definitely concerned in a lot of areas, specifically this one. The tone that's being set there is not one that gives me a lot of confidence that we're going to be able to salvage some of the important pieces.
Now, it's difficult to take the 109-page report, even if you sub out take away from the reference material in the back, and so to sum up really what you concluded. But there were a number of things that I found in the report, the sort of major themes that I saw going through. I talked about kids, early intervention with kids, jail diversion. We have already referenced criminal justice. I mentioned that 20,000 people in the county jails have a mental illness. Also, another thing I thought was interesting was that somebody with an untreated mental illness is 8 times as likely to be incarcerated as somebody without an untreated mental illness. So there's obviously a huge link between criminal justice. And in fact, we did a symposium on race and policy a couple weeks ago, and the police chief of Houston, former police chief of Austin, Art Acevedo, specifically called out a desire for the legislature to fund mental health programs for cops. That there needed to be screening of I thought that was a really interesting part of this. So the criminal justice piece is good. There's a workforce problem.
Yeah.
185 out of 254 counties in the state of Texas have no psychiatrist. True fact?
True.
I mean, it's stunning to discover that. And then the last thing was somehow integrating physical and mental health as a holistic approach. Those are big themes that I pulled out at least.
And many of I think the shortage piece, the access, access in terms of insurance is one piece of it. The other is just the professional.
Right. So the healthcare problem in Texas is often misperceived as simply an access to coverage problem when we have also an access to care problem.
And I really want to emphasize one thing here with respect to what we're investing and those issues that you're identifying and how important they are. In the past, I think too often folks measured what we're doing in behavioral health by how much money we're putting in and how many people are being seen. And that is one way to measure, what you're doing. But I think we've turned a corner where we're now measuring how effective we're producing outcomes.
Right.
And so instead of just reducing waiting lists, we're looking at, are the treatments that are being delivered actually doing the job we want them to do? Are they being seen over and over again, the same folks? And so I think by focusing on outcomes and looking at recovery, as some folks testified, is really a journey, not just a result, we see better ability of statewide to measure these. And so when you look at those statistics, we don't want to look at them in a vacuum. So we want to know that if we're going to help criminal justice by jail diversion programs or competency restoration programs or making sure that we're doing some things on the front end to keep folks out of that system, we also thereby help the problem in our state hospitals, which also helps the problems in county jails.
It all reverberates, right?
All these things have a relationship to one another. So just attacking one thing or saying if we solve this, then we can move on to something else is simplistic.
You bring up an interesting point. We often focus at the legislature and in the budgeting process specifically on inputs. And there's increasingly been at the legislature a focus on outputs. So like in higher ed, for instance, the whole concept of outcomes-based funding. Rather than paying people based on enrollment or some kind of a formula that's on the front end, we ought to actually be incentivizing higher ed institutions to get people through and educated and get a degree certificate. Is there an outcomes-based funding model for mental health, Representative Moody, that we should be considering in some way?
Oh, goodness. I mean, I think that's... I think that would be difficult to put together, but I think the lessons...
But I guess to Representative Price's point, we are focusing more and more on the results.
Well, and I think that goes back to the early part of the conversation, which is, you look at the budget and you look at a number that's been, increased marginally this biennium in this proposed budget.
And in each of the last 2 sessions as well.
Exactly,
right?
and I think that's great that we've been paying attention to it. I think what's being done this time is to actually look at the nuts and bolts of how these services are being developed. And while the transformation from where we are now, which is a mental health care delivery system that is, I think, by people working hard, but we're not getting to where we need to get to, and transforming it over the next, I think, probably 10 years. Yeah. This is where we lay the foundation. We can do transformative things this session, though, and the chairman mentioned state hospitals, and he's visited, I think you visited them all.
Well, not all of them, but
almost
several,
all.
Yes.
I mean, there is a big price tag out there for bringing state hospitals up to snuff. There's a deferred maintenance in that system that if we take that this session and find a way to fund that and bring those buildings up to modernize those facilities, we're going to open the door for a lot of partnerships, and that's one of the truly transformative things we could do this session, along with some of these other
this is something that we've heard about not only in the mental health area but across the board, that state facilities, state office buildings are just like from the it's like Shutter Island, it's like some old It's like, this is kind of old fall down, like scary movie facilities.
True.
Well, we started providing care in state hospitals in Texas in 1861.
Some of the buildings look like they haven't gotten an update, actually, right from there. So since we all accept that this is a problem, not only in the mental health area, but across the board, why is this not one of those unicorn-like one-time expenses that would allow you to take money from the rainy day fund? We're going to have $12 billion in the rainy day fund by the end of the biennium. Let us stipulate that the budget cycle sucks and that the budget is not going to have as much money as you possibly need. You are going to have maybe as much as $5 billion over the floor that you all set for the Economic Stabilization Fund. Couldn't you, under the heading of one-time expenses, do some refurbishing of some of these facilities?
I think it should be a priority this session.
Well, a Democrat saying you want to spend money from the rainy day fund is not exactly news.
Well, like I said, this is not, like you said, well, we began this conversation about not being a partisan issue.
Correct.
This is not a partisan issue. This is about, first of all, delivering good quality care, but also opening up opportunities. And the opportunities that we can achieve in this state, so this is where I think this is where, to my conservative colleagues, if you want to develop, look at MD Anderson in Houston. Look at people coming around.
Centers of excellence.
People coming from around the world to get treated for cancer here in Texas. Why are they not coming from around the world to get treated for mental illness, mental health issues? They should be, and they can be, but we've got to invest on the state side of things. And that's how you develop these. And so it's an economic driver, too. So you want to talk about, from, I think, on business principles, conservative principles, I think that's the way you talk to folks.
Well, in fact, you reference in the report CPRIT, right, the Cancer Prevention Research Institute of Texas, and the investment that was made by the state and by the voters explicitly in a long-term project to make Texas ground zero for cancer research, prevention, treatment, and all that. And as you say, Representative Moody, MD Anderson at the center of that, but not only there, and you theorize that can be the same for mental health. Representative Price, go there, please, on the rainy day fund. Yes or no?
Well, we could certainly, and I don't believe anything should be off the table. I think Joe's correct. If you look at what we spend on behavioral health, and we've referenced it several times today, it's an enormous price tag already. If you look at what we've done with CPRIT over a longer period of time, look at those numbers. I mean, we're talking almost identical numbers, but we're spending that amount on behavioral health per biennium. And so we have a real opportunity to be the leader, not just among the state with respect to what we're going to do, but across the country. Right. Because we can transform the way mental health is treated in Texas. We can prioritize our facilities, and we can't do it all at once. And so it'd be unreasonable to think that we do it all at once. But if you look at, and this is a very common issue, across the state, if I talk to any law enforcement officer, the one or second priority that they will always bring up is bed capacity. Yep. They are law enforcement. They're not professionals trained extensively to deal with mental health crises, although they're trained more now than they ever have been in the past. And so if they say we have to dedicate resources to dealing with and transporting patients to and from facilities, trying to find bed space, that's difficult. They're not getting great treatment, and the law enforcement officers are inefficiently dedicating time and resource to that issue when they should be protecting folks on the street and doing their job. So I think that, as Joe said, if you look at it from a very conservative standpoint, there are arguments to be made. Now, politically, it's very difficult to get in the rainy day fund.
Well, you got to get 2/3 from the Senate, 2/3 from the House. You probably have a better chance of getting it in the House and the Senate. But again, Republicans supporting taking money out of the rainy day fund, to be honest, is not a normal occurrence. And I've had a number of, Representative Darby, chair of the Ways and Means Committee, for all we know, chair of the Energy Resources Committee, for all we know, the next budget chair, saying out loud in public, we need to be considering this seriously. That is a marked change from previous sessions.
And I think that, everything should be considered and the dialogue should be had. Whether or not it actually happens that way, I don't know, but there's also, general revenue bonds. There's other ways to finance.
Well, but I'll point out also, Representative Price, that you all in the House put a draft budget out that's several $billion above the rainy day fund. There's not any way to do that above the revenue estimate, pardon me, that the House budget draft is several $1 billion more than the revenue estimate, than you had available to spend. It sounds like you've already decided to take, because how do you do the math unless you dip into the rainy day fund?
We have to start somewhere, so it's a process, and certainly we will
Right.
we will get there. I'm that's the only bill that has to pass. So eventually we will come to agreements.
It'll be somewhere. The debt or the bonding issue is interesting. Representative Moody and I talked about this earlier this week. The same people who don't like touching the rainy day fund also don't like debt, and this comes up every 2 years. Well, we're not paying for stuff, and so municipalities often end up incurring debt in the form of bonding to do things that the state used to do that they're no longer going to do, but that the community demands that they do. And then the people who complain about state spending being too high then turn around and complain when municipalities take on debt. Are you open to the idea of debt being part of this conversation?
I'm open to it. I think we ought to have the conversation. I think that when you look at leveraging our health science centers across the state of Texas, when you look at remodeling, refurbishing, rebuilding state hospitals and step-down treatment centers and a continuum of care that has to be in place to actually and effectively treat the millions of Texans who suffer from mental illness, you have to look at this as a priority, and you have to look at it financially as well. So you look at low-rate environment, you look at where we are currently. If you're going to make an investment, as we said at the beginning of this process, you can pay now, you can pay later. Are we willing to, even look at financing or look at rainy day funds or look at priorities within our current budget?
How about public-private partnerships?
I think that's the best.
Transportation and higher ed, to name two big-ticket items in the budget, have increasingly turned to public-private partnerships to get facilities built or to get projects on track, and the world hasn't ended.
Go look at the Haven for Hope in Bexar County in San Antonio. It's one of the greatest examples of a public-private partnership and how effective it is at treating folks in their community successfully, both in substance abuse and homelessness and mental illness. And really, I've always said from the beginning of this process, and I think Joe and I agree on this, is that the state of Texas can demand or mandate that programs be implemented, but every region is so unique that it will be effective in some and less effective in other areas. But if you can incentivize communities to come up with solutions to the challenges they face locally and maybe provide matching funds, similar to what we did with SB 55 and veterans' mental health issues last session, that is something that is very effective, has shown to be very effective, and actually probably produces better outcomes on local level than anything we can mandate from.
You're not advocating for local control, are you?
I absolutely am.
Okay, just checking. My ears perked up. Representative Moody, it sounds like facilities may be, in the end, if not a priority, maybe the priority that comes out of this.
I think that if we want to truly take the opportunity that we've been given, and it feeds into the public-private partnership idea as well. The public part of it, us bringing these buildings up to code so they can be utilized in these partnerships with our academic institutions, with other private industry that want to get involved in these things. So if we put our part on the table this session, and look, I think, and it's a difficult conversation to have, and I don't pretend to know the inner workings of the Republican caucus, but. It's a difficult conversation to have, but like you said at the beginning of the conversation, this is something that it affects people no matter what district we come from, urban or rural, suburban, doesn't matter. And so if we really want to create excellence in this area for Texas and create opportunities in this area in Texas, then we need to look very hard at spending out of the rainy day fund to bring those buildings up to snuff.
Well, look, let's just talk about the fact that in a lot of these communities, these facilities may be very large employers. And you may have members who are thinking about the community back home, and whatever else they think about this spend or about this issue, they think this is actually a good, there's a lot of ways at it. So facilities is one. The workforce thing, which we alluded to or talked about specifically earlier, I'm interested in a reference in this report to education incentives to help solve the workforce problem. So are you talking about, it's almost like an AmeriCorps, but for mental health. So if you go into this field and help us with our workforce problem, we're going to do some forgiveness of loans, or what's the deal there?
Well, we do. We currently and recently have programs that incentivize mental health professionals, and there are loan repayment programs, at least at the medical professional level, that I think are good and need to be funded and continued. When we look at graduate medical education slots, and you mentioned the lack of psychiatrists, That is a problem that can be improved, but it's not going to change overnight. And so, for instance, one way to improve that, I think, is emphasize telepsychiatry and telemedicine. That may not change the number of psychiatrists, for instance, right away, but it will improve access.
Gives you access to people with
many
expertise.
who need it. And
Right.
so there are effective programs out there now. They're not being replicated statewide, but we can do it. And I think
Right.
when you look at reimbursement for certified peer specialists and support specialists, I think
Yeah.
that's important. Providing incentives for a broader mental health workforce is absolutely important for us, because if we don't have it,
Right.
That's one of the legs of the three-legged stool that we're going to fall down on in effective treatment.
The other
Yes.
issue on workforce that is reciprocity. So folks that want to come here to Texas to practice in these arenas, and we have barriers for them to do that. So we need to look at our system of reciprocity.
What kind of barriers?
So I think what we heard in testimony was that I don't know that our system allows people to waive in a quick fashion, determine if they've been licensed somewhere else to come in and practice here without getting. I don't know all the ins and outs of it, but there was testimony that we heard time and time again was we need to look at the way we bring people.
So a process fix could, and then again, doesn't have a fiscal.
And so that's one of those things. I was going to say, going back to the original conversation, that's one of those structural changes that doesn't carry a price
Doesn't
tag.
cost. So I was remembering that we had done something at the Tribune on mental health in college campuses, and I went back and looked, and actually this then popped back up in your report, that the current wait time for mental health services on college campuses, public university campuses in the state of Texas, appointment wait time to see a mental health professional is now 2 to 3 weeks.
What
do you do about that? I mean, higher ed is definitely one of these lower tier, inevitably, in a tight budget cycle. They're not at the top, higher ed, right? So how do you solve that? That seems like a simmering kettle. What do you do about that?
One thing we did last session, we passed House Bill 197, which didn't increase resources necessarily on campus, but it allowed or provided for the universities to put on their website the mental health information that they provide on campus or in the community, so that students, if they are reluctant, for instance, to go, they at least have access to know where to seek that help. And every university and every college is different with respect to what they provide on campus.
Yep.
I'm going to point to a community college, Del Mar College, that testified in front of our committee as a really good community college that does incredible work within their budget, providing access to students, providing proactive outreach efforts to students, so that you're reaching students who are very vulnerable, who are in a very tense environment, who might need the help but are reluctant to go seek it.
Yeah.
They're doing some innovative things, and students, across the systems of UT and A&M are seeing, on their branch campuses, sometimes they're doing some very innovative things as well. I think, outreach is a big part of it. Education is a huge part of it in terms of just reducing the stigma and helping students understand that there are resources out there, not only on campus, but in their community.
But nearby.
Right. So, you have to understand their main mission is not necessarily for mental health treatment. Their mission is to educate and graduate students.
Right.
So this is an important function of that, but it's not their primary mission, so they devote different resources differently across all the campuses.
Before we go to questions, last thing, Representative Moody, one thing I also noticed, and it is a topic that I think comes up no matter what the main subject of the conversation is these days, the demographic change in the state of Texas, that individuals with limited English proficiency in the state of Texas also index higher in terms of the likelihood of having some mental health issue that needs to be treated. So we're moving to a population of Texas that is going to have a lot of people with limited English proficiency, at least in the short term. How do we need to be getting out ahead of that problem?
Well, I mean, in this arena is not the only one that we're going to have. That
No,
problem.
so, absolutely agree.
But also part of the that dovetails with the workforce conversation is who are we bringing into these professions? We had the state demographer testify in another committee on education and healthcare, and we're not graduating folks that are bilingual, that are providing services. This impacts professions across the board in the healthcare industry, not
Correct.
just in the mental health arena. And so we're not bringing those populations into the healthcare workforce. That is a big problem because the demographics are shifting quickly, And if we don't have people also within those populations coming into the healthcare workforce that are going to provide those services to people in those communities, then I think that creates another barrier, language or otherwise, it creates another barrier to actually receiving services. And that's one of those that I don't know that people have really fully got their arms around.
Well, I know we could go through the stuff in this report all day, but let's go ahead to people in the audience and take questions. Agnes will walk a microphone around. We'll take as many as time permits. Gentlemen in the front, we're happy to walk through. And then why don't we do front, and then Ms. Lava third. So we'll do here, and then the first table up next to that one, and then Ms. Lava. And then we'll come to the back. Ms. Cowan in the back then. Yes.
Representatives, my name is Jacob. I have a physical health issue and a mental health issue, a serious mental health issue, because I take 1, lithium, 2, lamictal, and 3, levodopa. At any rate, what I have to say is, I have many things to say, but, one, I bought a shirt and I would like you, Joe, and you four to autograph it for me.
Right.
And also I have some articles for y'all to have about this immigration and how I'm pro-life. And the question I have is this. Would you say 1 in 5 people have in the state of Texas have a mental health issue? 1 in 7 have a serious mental health issue. And would you say that the unfortunate women that go to abortion clinics have a mental health issue?
Would I say that is that more prevalent?
Yeah.
I don't know that we took testimony on that particular issue. I know that we definitely heard about postpartum issues, and that a lot of women in Texas, the primary source of mental health care is they're going to their OB-GYN. So I mean, those conversations are happening at that level, and I think one of the recommendations that was made in the report was to really to extend the services that'll be covered as part of those visits. Yeah,
and just to continue on the integration of behavioral health and physical health, how important that is. I mean, it's really important. We learned through our committee that so many Texans are willing to discuss or present symptoms with their primary care physician. They may not go seek out help from any other physician, for instance, a psychiatrist or maybe a counselor or psychologist, but they're willing to talk to their primary care physician. But the primary care physician might not, be as trained as they would like to be with respect to psychiatry. They might not have as much exposure to that. They might not get reimbursed for taking an effort, to treat them or refer them. So, there's some barriers there that we want to break down, and that doesn't directly address the nature of the question. We didn't take testimony on that, but I think it does point to the fact that no matter what area of physical health, somebody may go see their physician for, the mental health component of that is always present. And what we can do as a legislature is break down some of those barriers, especially when it comes to parity and insurance reimbursement, to allow for more integrated care. So we're treating the whole person and not just their mental health or just their physical health.
Good answer. Here, let's go here, and then Ms. Lava. Ma'am?
Yes. One of the things, and you just mentioned it, was parity in treatment. We had a daughter that was diagnosed with an eating disorder. She's 26 now. When she was in 9th grade. We have insurance, but because there wasn't parity in treatment, and because the state of Texas doesn't recognize eating disorders as a serious mental health illness, we've been unable to get her treatment covered. We've had to pay so much out of pocket. Right. Eating disorders are one of the has the highest rate of mortality for serious mental health illness. So have y'all addressed that and parity of treatment?
Yeah. That come up in your
We did address parity quite extensively. We didn't get into the classification of certain, for instance, designated, mental health disorders with, specifically. What we talked about, though, was parity at length. And to me, that's one of the largest issues, really, if you want to highlight something that is, necessary to correct in order to improve access and in order to really provide effective treatment. Parity is one of them. Now, we have existing federal and state laws. The problem is, I think, you've got this constituency, if you will, that is, one, hard to advocate sometimes for itself. So when you are, for instance, suffering from mental illness and you don't believe that your non-quantitative parity or coverage, for instance, like medical necessity, is being adequately addressed, well, one, you could appeal it with your insurance company. We all know that that doesn't always turn out the way you would like it to. I think that some cynics who testified, obviously, in our committee too, would say they know that, and so they are willing to make you appeal or go through that process. And so I don't necessarily know if that's accurate, but what I do know is that there are many things that we ought to be working on, and we have some bills that we actually are in the process of working on that would increase transparency with TDI, for instance, give them a little more enforcement power, or at least provide a forum for folks to start to, really register these complaints, because even though they testified the number of complaints they've received in the past is relatively low, we know that the actual occurrence of folks who are not receiving coverage on par or on level with what their coverage actually provides for is significantly higher.
Take Ms. Lava in a second. What do you do about that? So you have vulnerable populations all over the state of Texas that don't have the power to be effective advocates for themselves. I mean, what did we just see over the last couple of weeks? Medicaid therapy cuts, special ed cap, kids sleeping in state offices. It's fair to ask what the state of Texas has against vulnerable populations, right? I mean, there are a lot of issues in which vulnerable populations have found themselves in the crosshairs, and one of the reasons that gets to this point may be that there's not an effective method for those populations to be advocates. You just have basically said.
Yeah, well, that's why I said it,
yeah.
because I mean,
Yeah.
I think that's accurate, and I believe that by raising this issue to the surface, by bringing up the parity matter and making sure that we talk about it, that we're educating folks who are covered. I think a large number of folks who believe they have coverage because their contract says they've got it, they don't know what that means.
Exactly.
They don't know exactly how to deal with their providers or their carriers about that. So we're gonna work on that to make it a priority, to increase awareness and education, but also give some better powers to those who hear these complaints so they can do something about it.
Excellent. Ma'am, right there.
Thank you for spending as much time and effort as you have started to do on this topic. I have a question. It was mentioned early on that well over 1 million people who have mental illness is from the veterans group.
Right. 1.7 million, yeah.
And I'm wondering, since the military and VA seems to be a federal priority at the moment, as mentioned by the president, how, if at all, you looked at cooperating for funding sources as well as spending sources with any levels of the federal government for that population.
Representative Moody, I know you're thinking a lot about veterans on this issue, right?
And we've got a significant veteran population in El Paso, so this is an issue we hear about a lot, and our congressman there works in a bipartisan way to do things for our veterans back home. This is one of the arenas that I think we can find some room to work, because at least so far the rhetoric from the new administration is that they want to fix the VA, they want to address these service shortages. They probably can't absorb all of that within the VA system, though. So, I mean, we need to look for ways to partner at the local level, partner at the state level. I think there may be an opportunity, and I think within the budget increase you saw here there were some veteran-specific items. So I think that was kind of a hat tip to the idea that I think we're going to look for opportunities to be able to partner with the feds on those particular issues.
I think that's true. I think there's opportunities to partner with them, but I really believe, too, that we have to take the lead. And Texas has done a good job with that in the past in this specific area. especially after last session with SB 55. But I do also want to emphasize peer support in you know, and how important that is in our veterans community. I know that it's true, but there's groups, and I hesitate to single out one because there's so many that are doing such effective jobs, and our Veterans Commission in Texas, I think, is doing an outstanding job reaching out. But Mental Health America in Houston has done a great job with respect to veterans programs and peer support. You know, veterans are unique, and it's a unique community, and so they may be less likely to reach out on their own to someone that is not similarly situated to them with respect to their background in military service, but they're much more likely to receive peer support from someone who has experienced the same military background or life experience that they have, and it's been more effective. And so I think we take the lead, we keep doing what we want to do and pursue the programs at a state and local level that have been successful. But we look for those opportunities because obviously the VA system is very important, but there are some gaps in that system as well that we as a state can pick up and prioritize. So I think that's where we focus some effort in the committee, and that's where we also see some opportunity.
Good. Ms. Cowan and then Mr. Hammond.
Thank you. I am a trustee with the Austin ISD School District, and I know that we had some of our staff testify before the committee, and we're very grateful for allowing that. In Austin ISD, we have 19 campus-based mental health centers on our campuses. All of our high schools and a few of our targeted middle schools have this. And Senator Watson has introduced Senate Bill 411. One of the struggles that we're having is 16 of our centers, we work with the Austin Travis Integral Care. And so it's a good partnership that we have, and it's funding that. The other 3 don't qualify for that. Our students don't qualify, yet they still have their own conditions. And Senator Watson's bill is encouraging insurance to accept our providers onto their provider list. Right now, they're being denied, saying that there are too many providers in that our part of town. And yet, we know that if you're going to talk about trying to do preventive work, getting our kids in their schools is the best way to prevent that, get them educated, get them graduated. And so we hope that we'll have some support for that.
Question is, can you support, will you support
Watson?
Watson?
Senate Bill 411
Right.
for us and perhaps carrying it on the House
Thanks for
side.
tying that down.
Yeah, you know. No, I think actually one of the most tangible things that and I know testimony that we took from y'all, one of the most tangible things that we saw, tangible benefits we saw, were providing those services within the campus. We heard testimony that when schools, we saw at-risk schools or low-performing schools, they brought those services, put them on campus, and showed us the metrics over the last 2 years and the increase in all the things that we're gathering data on. I mean, those are real benefits that we're providing, not only that we're taking care of physical health, but mental health in those campuses. So yes, to your question, but it's one of the, and I think it's actually in the it's a recommendation in the report as well.
Yeah, and I really appreciate your willingness to testify before the committee. We also had Hutto ISD and Elgin ISD, and they were great examples for those who aren't familiar with them of integration of mental behavioral health treatment on campus or on a district site so that not only students can be treated, and we know that's the most effective form of treatment when it's early, but more importantly to me, or as important, was the fact that families of those students were also treatment was made available to them, because sometimes their issues stem from problems that exist with a mother or a father or a family member. And so we heard that their graduation rates, their attendance rates, there were ancillary benefits that you might not necessarily associate with that integrated treatment and accessibility, but I think it absolutely empirically proved to be true. So thank you for that.
Great. Mr. Hammond will be the last question before we end. Sir.
My question is with the Medicaid block grants for both of the members, are you concerned about the block grants being capped once they're established? And second, what are some specific examples of things that could be done differently with regard to mental health under a block grant that are not allowed under the current funding stream?
Well, I'll start. I guess, I guess with respect to the cap, I guess there is concern. There's still a tremendous amount of uncertainty as far as, we can see with respect to what that ultimately could look like. I think it's a concern, though, because you have to you have to always work within whatever, set of numbers you're given, I guess. But more than that, I think it provides flexibility. What would be innovative about it is, for instance, and I see Sonia Gaines in the back. She's the Associate Commissioner at HHSC who oversees the Coordinating Council. So we've mentioned these 18 agencies. Right. We're providing mental health and behavioral health treatment across 18 agencies. Well, she's head of a group that coordinates those efforts so we don't have duplicity. Well, if we were able to provide more flexibility about how we're providing services across agency lines, with respect to reaching some of the same population that might need services from different agencies. Those are things that I think with flexibility we can do in a block grant that are a little more difficult in the structure we have right now, where we fund an agency, they provide a service, we fund another agency, they provide a service. More coordinated efforts I think are key, and frankly I'd like to provide incentives to local communities through matching funds to incentivize public-private partnerships. Yeah. I'd like to see local communities address the challenges that exist there more frequently than we've been able to do so far under our current system of funding, because frankly I think that would provide the most effective results for Texans in different regions of the state.
Rep. Moody, anything on that?
Well, I mean, the flexibility is always the argument when you talk about block grants, and that's the benefit that comes along with a system like that. I think that, to Rep. Price's point about what we can do at the local level, we heard, I mean, that's really the wealth of information that's in this, that this committee went through, was some of the creative things that are being done at the local level, a lot of them through the waiver program, but the ideas that have been unlocked, these partnerships on campuses, different programs for veterans. So we need to maybe look at those, and the committee report actually highlights best practices in some of these new programs. So if you give the flexibility and you have you just want to make sure that we're not, you don't want to chase after some of these things in the name of flexibility, and then we don't have any accountability that comes along with it. That's the part that makes me, I mean, we've heard about, I mean, Evan, you brought up, I mean, Texas's history of not being great with vulnerable populations. So if we just unleash those funds, we need to be very, we need to make sure that we have some accountability as well, because these are delicate situations in a lot of ways. So if we're just throwing money without any tie-ins to some accountability, we could have some problems. So that's the one thing that I would put a caveat on.
Good. This is a great conversation. How wonderful to have some time with you to talk about this. Please give Representatives Moody and Price a hand. Thank you all. We'll see you again. Appreciate it.